Welcome everybody to our lecture series where we're continuing on with some common topics in cardiovascular MRI. Today I'm going to be talking about the role of cardiovascular MRI for diagnosis and prognosis in acute myocarditis. This is essentially an update on where we are today in 2015, and please feel free to ask any questions as we go along. Just a few disclosures to put up first. So what we're talking about here is acute inflammatory myocardial disease, which really the first thing that we should do is really define what that means. And so myocarditis is essentially inflammation of the heart muscle in the absence of ischemic injury. You can see here, as shown on the left-hand side, that it can present in young people, such as this lady that died suddenly, was resuscitated and had very severe left ventricular dysfunction at age 30. But that's about 10 to 15% of incident cases of dilated cardiomyopathy. So it's a significant prevalence in the new onset heart failure community, but also about 5 to 20% of incident cases of sudden cardiac arrest, this unfortunate person having both at the same time. But it can also present like an ACS or acute coronary syndrome-like presentation, which we'll talk about later. Those people typically having a higher prevalence of imaging findings, certainly on MRI, and also can present with arrhythmic events such as tachyarrhythmias, VT, or in some cases heart block. So what are the common causes of myocarditis? Well, clinically, we see really two predominant causes, that being viral and autoantigens. And so viral ones, very commonly parvovirus B19, Coxsackie virus, human herpes simplex virus. And then under the category of autoantigens, really what we're talking about are the autoimmune diseases. So we're talking about sarcoidosis, lupus, rheumatoid arthritis, Churg-Strauss, and that spectrum of diseases. Once we get beyond those two common categories, we see kind of a smattering of different things that are much rarer. The ones that we sometimes see are hypersensitivity reactions to drugs and things like that, but these are much less common. So irrespective of what the inciting event is, we see a cascade of events start to occur. Really, this starts with cytokine activation and T-cell activation that leads to cellular necrosis. And this is often associated with hyperemia in the regional tissue and also edema. And these are going to be important imaging markers as we see, certainly for cardiovascular MRI. Then we transitioned into a subacute phase where this is where macrophages start coming in and trying to clean up the debris, the cellular debris, and you get fibroblast activation, and we start to see resolving edema with more mature layers of collagen laid down, where we move now into the healed phase where we have replacement fibrosis. And we believe that the amount of replacement fibrosis that we experience is dependent upon the initial amount of necrosis. Once people have reached this convalescent phase, however, we do see some patients that experience recurrent inflammation and patterns of injury, and we believe that that's either that they have not eliminated the inciting event or the agent that was causing the injury, or that they've actually developed autoantibodies to the myocardium that continue the inflammatory process. So what are our goals of imaging? Well, clinically, we want to first evaluate patients with new onset heart failure and identify the cause. And often what we're doing is trying to establish whether or not we've got an ischemic or non-ischemic cause. And in patients that present with chest discomfort or troponin elevation, we're often trying to exclude ACS or rule in an inflammatory myocardial disease. But beyond that, we may actually be able to define the difference between viral and non-viral agents for the inflammation. And this is important because it may actually dictate early care. So for example, if we identify somebody that has classic features of either sarcoidosis or Churg-Strauss, etc., we may actually have different therapy that we may apply to them. After that, there's a potential role for early risk stratification, and that would be with respect to not only evaluating the severity of LV dysfunction, but potentially the likelihood that that person's either going to have an adverse outcome over the first 30 to 60 days, or may actually go on to develop a high likelihood of early arrhythmic events. But especially what we're interested in is who's the most likely to have functional recovery versus those that are not. Once we actually initiate therapy, we then can look for resolution of left ventricular dysfunction, but also would be very interested in being able to scale or look at how the inflammation is settling down with our therapy. There are obviously other secondary complications that we may want to keep an eye out for as well. And then finally, we know that patients that do not recover LV function may be candidates for either ICD or CRT, and so potentially imaging has a role there as well. So what can we use to image myocardial disease or inflammatory myocardial disease? Well, right now, these are the four most commonly used cardiovascular imaging techniques. We have echocardiography, nuclear imaging, CT, and cardiovascular MRI. And echocardiography is obviously widely available and indeed is invariably performed in every one of these patients. So it'd be very unusual for a patient to present with any form of cardiomyopathy and not have an echocardiography examination performed. Nuclear imaging techniques, SPECT imaging is widely available, PET less so, but we're going to talk about some of the strengths and weaknesses of nuclear in this clinical setting. Now, CT is now moderately available and has some early potential roles, but is very much in the experimental or preclinical phase for evaluation of things like myocarditis. So that brings us to cardiovascular MRI, which, granted, is less widely available, but is increasing in availability internationally at tertiary care centers. So if we take echocardiography, we can certainly see signs consistent with acute myocarditis. We can see often wall motion abnormalities, regional thickening associated with edema, and we can often see associated pericardial effusion. However, this really lacks specificity because any acute myocardial injury, be that ischemic or non-ischemic, can lead to the same patterns. So this is where there has been some emerging interest in the use of speckle tracking echocardiography to look at novel markers of inflammatory disease in the myocardium. And here's one example that was done from the Mayo Clinic with 45 patients presenting with acute myocarditis. And they compared to 83 healthy controls. And what they did was did 2D speckle tracking to look at longitudinal circumferential strain. And they used the reference standard of a clinical diagnosis of acute myocarditis. And certainly what you see is that in patients that do have acute myocarditis confirmed, especially in obviously those that have more significant LV dysfunction, that we do see significant changes versus controls in both longitudinal and circumferential strain. In that study, they were able to identify that those patients that had normal versus abnormal strain profiles, they did seem to have a significantly higher event rate over the upcoming 36 months. This was adjusted in multivariable analysis for baseline ejection fraction. And so it did seem to suggest that strain metrics may have the capacity to identify people at elevated risk of events following the suspicion of acute myocarditis. So nuclear imaging is something that's been around for a very long time. And if you look at the initial gamma cameras that were planar, they actually had quite a bit of challenge in differentiating pericardial from myocardial inflammation and generally used higher radiation doses. But as SPECT cameras became available, both using technetium and gallium, there were some early studies that showed a potential value. Now, technetium would essentially show fixed perfusion abnormalities consistent with areas where there's very little perfusion with either necrosis or scar. That can be argued as to how much value there is in differentiating versus, say, an ischemic injury. But gallium had the potential to actually identify areas with increased metabolic activity associated with activation of the immune cell lines. So that actually had some early promise. But then really what evolved was trying to find something a little bit more specific to the myocardium. And so indium-labeled anti-myosin antibody imaging was tested for a period of time and had some clinical uptake within the late 90s and early 2000s. But because of lack of availability of that tracer and radiation exposure, it's really fallen off. And so really where we are today is some interest now re-emerging with PET imaging with FDG. And I'm going to come back to that a little bit later because we're going to talk about that when we talk about hybrid imaging with PET MRI. So now we're going to come to the contemporary use of cardiovascular MRI, and really that's the focus of this talk. What are the different imaging techniques that we use with MRI to identify acute myocarditis, and what's their potential value and pitfalls? And so we're going to start with the established techniques, which are listed on the left-hand side, and then we'll move into some of the more emerging and future techniques that we're exploring. The workhorse of cardiovascular MRI is SSFP-based cine imaging, and that's what you're seeing on the screen here. So this is a short-axis image of the in the mid-ventricle, and this is of a patient with acute myocarditis. And so in this patient here, in this patient here, they were not identified to have any abnormalities by echocardiography, however, had a positive troponin and a normal cath. And so the patient came to CMR where, at least visually and objectively by LV volumes and stroke volume, the cine suggested there was normal LV function. I won't comment on the strain characteristics of this patient, but we will come back to it later in the talk. And so what we're able to see on here, however, is some subtle signal changes that will become a little bit more apparent on some of the later imaging applied in this patient. But it allows us certainly to look at regional wall motion, regional thickening, and in the case of this patient, a very trivial pericardial effusion. So did we get much value from this? Well, arguably not at this point. But the true strengths of cardiac MRI really come into tissue characterization. And so where we have the unique capacity with CMR is to be able to allow certain characteristics of tissue to emerge or be suppressed. And in this situation, what we're doing is applying what's called a T2 weighted image, where we're asking the protons that are bound to water to stand up and wave little flags for us and give us a water map of the tissue. And we're able to suppress other characteristics such as fat or blood pool signal. And in doing so, we can look for either regional increase in signal, as is shown in this patient with myocarditis here, where there's a high signal in the inferolateral wall, or you can see patients that have global increase in T2 signal. And as we'll talk about in a little while, we have come up with some criteria to try to establish what's outside the normal range. And typically we'll apply a muscle to a myocardial to skeletal muscle ratio of greater than or equal to 2.0. And if we apply this threshold, you'll see in this patient that we're using as an example, we see an area here that indeed has increased tissue signal, suggesting that there is edema. The next technique that we have available to us is one that's used maybe not as consistently at sites, but is early relative enhancement. And the idea behind this is that if we do a T1 weighted image, both before and following, early following contrast administration, we may be able to get an assessment of how much increased myocardial blood flow there is within regional tissue. And another way to do this is to do quantitative myocardial perfusion assessment. And some people have actually looked at this on the cine images as well, repeating cine images both before and after contrast. Irrespective of the technique applied, we can look for signal changes that may indicate that there's increased myocardial blood flow. In this particular patient, you can see we've done a region of interest, and compared to the baseline imaging, we saw an increase of 55% versus the native or non-contrast myocardium. And anything greater than 45% is considered abnormal. You can also look at reference versus skeletal muscle, and if the post-contrast signal is more than 4 times that of skeletal muscle, we consider that abnormal. Finally, we can use, after gadolinium is administered, we can look for late gadolinium enhancement. And essentially what we're saying here is that this is a marker of either a disruption of the cell membrane or an expansion of the extracellular volume. And it has to be a substantial marked expansion regionally to be able to be shown with late gadolinium enhancement. And we typically consider this to be a significant necrotic injury or replacement fibrosis. And this is really what has been considered the sine qua non, or the pathognomonic finding of acute myocarditis, which is SubEpicardial or mid-wall late gadolinium enhancement in a non-coronary distribution. And this would be a very typical or classic example of acute myocarditis. There has been some work done in Germany suggesting that potentially the regional distribution of late gadolinium enhancement may be associated with the etiologic agent in viral myocarditis. So, for example, this may be more consistent with parvovirus B19, whereas enteroseptal may be more consistent with human herpes simplex virus, although that hasn't been reproduced by other groups. But what is important is that other types of myocardial inflammation, such as patients with sarcoidosis, typically can have more characteristic basal, anteroseptal, and infraseptal enhancement, and sometimes we can differentiate between those types of inflammatory disease versus a viral etiology. All of this work, which was really being done in the late 90s to early 2000s, was put together in what was called the Jack White paper, and this is diagnostic criteria established for the CMR diagnosis of acute myocarditis, often termed the Lake Louise criteria. It's called Lake Louise criteria because a bunch of people got to get together and enjoy the view for a couple of days overlooking Lake Louise. I was fortunate to be part of that group, as was a whole range of people with really impressive CVs, much better than mine, that came together and for a few days tried to put all that wealth of knowledge together in a set of recommendations. So what were those recommendations? Well, it was recognized that cine imaging is useful and provides supportive evidence for the presence of myocarditis. However, it was also recognized that it's not specific for myocarditis and really was only supportive. So the focus was on tissue characterization. What we came up with was really 3 criteria that we felt if 2 out of those 3 were met, that we would have a high sensitivity and specificity for acute myocarditis. Those being T2 weighted imaging, suggestive of either regional or global edema, early relative enhancement, suggestive of hyperemia, and late gadolinium enhancement in a typical subepicardial or mid-wall pattern. And if 2 out of those 3 were met, we had fairly strong confidence that the patient had, in the right clinical setting, acute myocarditis. So let's see how that pans out. So we've been using a patient example up until now in this discussion. And this is the patient. It's a 37-year-old gentleman that came in with chest pain, an elevated troponin, and no obstructive CAD on a cath. And what we saw was that his short-axis cine image, as shown here, really didn't display anything obvious. The wall thickness was not that abnormal. There's only really a trace pericardial effusion. And we see the 4-chamber view really looks quite normal as well. And so the cine images were not really that contributory. However, we confirmed that there was elevated T2 signal using a threshold of greater than or equal to 2 times skeletal muscle. We saw that there was elevated global relative enhancement or early relative enhancement, and we saw classic patterns of subepicardial injury on late gadolinium enhancement. So this tells us that myocarditis has occurred, and it's occurred recently. And so in this patient, we have 1, 2, 3 criteria out of 3 for calling the diagnosis of acute myocarditis. Now, I do want to point out, however, that this doesn't always work. And the reason is that here we have an identical patient, 58-year-old female with chest pain, elevated troponin, and no obstructive CAD on cath. And what you'll see is that the cine imaging similarly shows normal global function, and really no obvious striking regional wall motion abnormalities, although I can confirm for you that the strain pattern would not be normal in the anteroseptum. If we look at the tissue characterization, we see a very clear area of increased T2 signal in the anteroseptum. And this is in a very classic distribution for LAD territory. In fact, you can see the LAD, the vascular bundle, right here. And the pattern of enhancement that we see on late gadolinium enhancement is not really that of a subepicardial process, but really just a diffuse speckling of the myocardium. And this is very common with transient severe ischemic injury. So this is actually a patient that had a thrombus in their proximal LAD and recannulated soon after, experiencing an ST elevation myocardial infarction. But the cath, by the time it was performed, showed complete resolution of the thrombus, and so there was no significant obstruction left. So I do want to point out that we always must apply criteria for the calling of a myocardial inflammation in the setting of good clinical judgment. And in this particular patient, this person had really a transient and aborted ST elevation myocardial infarction. So how does the Lake-Louise criteria perform in the right clinical setting against endomyocardial biopsy? And so there was a paper in 2012 that came out that looked at exactly this. And it was a well-conducted study. The total population, about 132 patients that underwent both CMR and endomyocardial biopsy. And what this showed was that in patients that presented within 14 days of getting their symptoms, they had a very high positive predictive value. And so positive predictive value in the 90% range for confirmation of myocarditis by endomyocardial biopsy. In patients, however, that were more than 14 days beyond their symptoms, you actually see the positive predictive value drop substantially, down to about 50%. So while endomyocardial biopsy continued to show evidence of myocarditis, the imaging findings associated with that started to fall off in being able to identify these patients. The other thing is looking at reproducibility. And while we see very good overall positive predictive, overall very good correlation between the prevalence of abnormalities between one site and another. And so, for example, here, LGE in a patient population with strongly suspected myocarditis being about 80 to 90% between two sites, T2 not too far off. So general agreement with prevalence. However, when you look at case agreement, you see that especially for T2 imaging, there can be substantial discrepancies as to what one investigator may call as abnormal versus another. And so I think this presents some caution. And this at least behooves us to try to have more awareness that consensus criteria need to be matched by consensus agreement on how to interpret. But if we do look at the one thing that we know is fairly robust with respect to most investigators are going to call it abnormal and call it the same way, that's late gadolinium enhancement. It really is the workhorse of tissue characterization in CMR. And if we look at this marker alone, it actually has a fairly good capacity to distinguish patients in this type of referral population. So for example, in this patient, in this cohort group here, 82 patients with positive troponins but normal cath, which is exactly the patient population that we're interested in, looking at if we use late gadolinium enhancement as a way to categorize underlying diagnosis versus an endomyocardial biopsy, we see a very similar distribution. In fact, we see a similar prevalence of myocarditis, although a little bit less in CMR, predominantly due to this group here, which was called Takotsubo cardiomyopathy. And that actually just brings into question whether or not endomyocardial biopsy is the appropriate tool to diagnose that or not, and actually makes us wonder about the pathophysiology as well, that it may actually be inflammatory. But if you take the Takotsubos out, we have a very remarkable similarity between these two groups. And so late gadolinium enhancement imaging is a very robust way in isolation without other tissue characterization techniques to be able to differentiate etiology of troponin elevation in the setting of normal coronary arteries. And indeed, what we see is that a lot of the prognostic work to date is based solely on late gadolinium enhancement. So Heiko Marholt's group in Germany has really published the majority of this work. And this study here was in 405 patients where they essentially wanted to look at what's the prognostic utility of doing an MRI. Now, their protocols typically include both cine imaging and late gadolinium enhancement, but not routinely T2 weighted imaging or early relative enhancement. And so this essentially is a study of looking at whether or not a normal CMR is of prognostic value. And if you have an ejection fraction over 60 and you have no late gadolinium enhancement, they called it a normal CMR, and using that binary dichotomous categorization, you can see a dramatic difference in event-free survival over time. In fact, if you have no late gadolinium enhancement and an ejection fraction greater than 60 with suspected myocarditis, you essentially had no events. Supporting this is another study that was recently published this year, and that is in 203 patients that had the diagnosis of acute myocarditis established by late gadolinium enhancement. And so therefore, they set the bar pretty high and said, we're only going to call acute myocarditis if there's late gadolinium enhancement. And so they looked at the incremental prognostic value beyond LGE. And what they found was it really didn't matter once you have LGE whether or not you have much else. So the presence of edema was not significant. The presence of early relative enhancement was not significant. And actually the extent of LGE was not significant. It seemed that once you have acute myocarditis with LGE, there wasn't much else that was going to affect your prognosis. The only thing they were able to find in multivariate analysis was that ejection fraction did influence prognosis. And so once you have an LGE confirmed diagnosis of myocarditis, if you have a low EF, you tend to do worse. But other markers of tissue injury really didn't make any incremental value. And this is consistent with the type of work that we've seen coming out for sarcoidosis, a different form of myocarditis, granted, but still nevertheless an inflammatory myocardial disease, where we see that late gadolinium enhancement is really the dominant predictor of adverse events. And in this case, having a hazard ratio of 32 in a patient population with confirmed pulmonary sarcoid being evaluated for possible cardiac involvement. So what can we do from here? We've gone through what we currently do with cine, T2 weighted imaging, early relative enhancement, LGE. We've observed that really late gadolinium enhancement in the current literature has emerged as a dominant tool for both the detection and prognosis of acute myocarditis. But what can we do better? Well, each one of these can be done better, I believe, and here's what's emerging as new techniques to be able to study this. The first is looking at 3D strain analysis of cine images, and so this is some of the work that's been being done here, which is looking at the novel concept that if you think about myocarditis as a predominantly SubEpicardial process that's working its way from the outside in, then we have the potential of CMR to be able to look at tracking of the epicardial surface in addition to the endocardial surface. So potential advances or advantages of this process would be that you can track to see whether or not inflammation starting at the epicardial surface may be a more accurate marker of acute inflammatory cardiomyopathy. Here's some preliminary work that we've got looking at a series of patients with myocarditis against a normal reference population and showing that there's a remarkable similarity in the distribution of epicardial circumferential strain versus what we see on late gadolinium enhancement analysis. And we've seen in this population an area under the curve of pretty robust 0.87 for the detection of acute myocarditis. So that's promising and I think warrants further investigation. In the field of tissue imaging, we've got the more recent advancements of T2 and T1 mapping Essentially, tissue mapping is akin to doing infrared imaging of biological structures, such as trying to chase down people in the woods after they've broken through a bank vault. And we use infrared imaging to try to track people down. Well, we can do the same thing with MRI. We can try to track down injury to the myocardium by using a color scale that represents different changes in T1 or T2 signal. And this has been looked at in acute myocarditis, at least in a preliminary sense, because T1 increases modestly with fibrosis, but more so with edema, so maybe quite sensitive to changes with acute inflammatory changes. And also T2 mapping inherently should change with edema as well. So it makes sense to investigate these techniques in acute myocarditis. And so if you look back in 2012, there was a study by Dinesh, actually, who's in Toronto, who was working with the group, Dr. Rahman and Simonetti, and in 20 patients showed that the use of T2 mapping was able to identify some significant differences between people with acute and resolving myocarditis versus controls, and indeed had a very robust area under the curve for the prediction of abnormal other tissue characterizations such as late gadolinium enhancement. So it suggested that there was the potential for T2 mapping to be a reasonable surrogate to what we conventionally use, which is late gadolinium enhancement or T2 stir. Superiority really wasn't established with this. It was simply showing that it was a reasonable surrogate. A similar study, but looking at a different cohort, was just recently published, and I thought was worth mentioning, is that in patients with severe dilated cardiomyopathy, so these are patients presenting with EFs in the 30% range, so not an acute myocarditis presentation from an ACS standpoint, but more of a dilated cardiomyopathy presentation, that these patients were found by endomyocardial biopsy to have a relatively high prevalence of what was considered myocarditis by histologic criteria. This prevalence is much higher than previously reported. So previously it was estimated to be maybe about 15% of new onset dilated cardiomyopathy would have evidence of myocarditis by biopsy. So this is a little bit unusual. But what they tested was the hypothesis that either T1 or T2 mapping might be able to identify those patients with active inflammation. Out of all of the things tested, T2 mapping was the only thing that showed any significant correlation, and a modest one at that. And so whether or not the utility of MRI for the detection of myocarditis according to their criteria is really a valuable tool or not is questionable, but it showed potential signal for T2 mapping in that setting. Now, T1 mapping has certainly had a greater wealth of study and publications, maybe not in this particular clinical arena, but there are a couple of studies worth mentioning that have really focused on native T1 mapping, so non-contrast T1 mapping for the detection of acute myocarditis. This was work published out of the Oxford group, and it was a study in 50 patients suspected of myocarditis in 45 normal controls. And you can see by the EF that these are mostly patients not presenting with heart failure, but usually presenting with chest pain syndromes. And they were assessed for really the ability of T1 mapping to identify or be congruent between people with or without suspected myocarditis. And this is important to delineate, that there really was no reference standard in this study. It was really looking at the capacity of an imaging variable to place somebody in the referral population or in the control population. That was their outcome measure. It really was not against any reference standard. So recognizing that, they showed that T1 mapping was as robust as late gadolinium enhancement. Really not any superior to late gadolinium enhancement, but was as robust as late gadolinium enhancement. And what it pointed out was that there was very modest performance of T2 weighted imaging, either using a stir-based technique, so a triple inversion recovery technique, or a bright blood technique. And so really pointed out some of the challenges with T2 weighted imaging, but the potential of native T1 mapping to be able to be as robust as a post-contrast late gadolinium enhancement image, which obviously has some attractive features, especially with people with renal insufficiency. The second paper that I will mention with native T1 mapping is one that came out this year, and is one that is very valuable actually, because it studied patients both at 1.5 Tesla and at 3 Tesla. It was done in 165 patients with acute myocarditis defined by clinical criteria, and that was a positive troponin with a flu-like illness, with ECG changes, and exclusion of CAD. And they have 40 normal controls. And you can see that this is a slightly sicker patient population. And so what was studied here was the ability of T1 mapping done prior to contrast to supplant really our other techniques, late gadolinium enhancement and T2. And what you can see here is versus controls, patients with acute myocarditis, and they also fortunately studied convalescent stage myocarditis, so they continued to image these people in 3 and 6 months, and also out to 1 year, I believe. And what we find is that there is a significant rise in the T1 signal, both at 3T and 1.5T, providing us some reference values actually moving forward as well for each of these field strengths, and showing a very nice decline in convalescence. And with this had the area under a curve of 1.0, which is always an interesting number to see, but they suggested that they had 100% sensitivity and specificity for the detection of acute myocarditis. But one of the nice figures in this publication is this one. And what they show very nicely is both at 1.5T and 3T, the steady decline in T1 values that occur over time, with normalization by approximately 6 months. And so this is actually a very nice figure that I think that promotes the use of T1 mapping as a quantitative serial measure of trying to look at resolution of myocardial inflammation. So what are other techniques that can be used? Well, not to do injustice to late gadolinium enhancement, we do have the ability to look at the inflammation pattern of myocarditis and look at it in different ways. So this is some work that we've done previously, doing isotropic imaging with late gadolinium enhancement at 3 Tesla, allowing us to get not only a quantitative assessment of burden using segmentation techniques, but also getting an appreciation for the distribution patterns of late gadolinium enhancement in different disease states. And if you look at patients with viral myocarditis versus those with sarcoid and other inflammatory myopathies, you actually do appreciate that there are emerging patterns, and typical ones as shown here. But this is a person that had a very clear viral myocarditis, whereas this is a person with sarcoidosis, and you can see that that there are very characteristic distributions that occur. And the other thing is the advent of PET MRI, and so this has become an exciting field. It's allowing us to now have hybrid scanners that afford simultaneous, spatially co-registered imaging of both MRI and PET tracers. So what is the advantage of this? What does PET have that MRI doesn't? Well, one of the things that we've been able to show, and this is a case that really exemplifies this, is that not always are we able to see with T2 weighted imaging the inflammation that we think is there. And so here's an example of a patient with acute cardiac sarcoidosis, so presented with heart block and chest discomfort. And what you can see here is that the T2 weighted imaging really doesn't show any significant changes. We do, however, see late gadolinium enhancement consistent with what we typically see with sarcoidosis, which is SubEpicardial at the anterior septum there. But look what happens after we've given FDG to this patient. We see very marked, intense uptake surrounding the areas of late gadolinium enhancement, looking like a wavefront phenomenon where the trailing edge is scar, but the leading edge is inflammation. And if we look at this tomographically, you'll be able to see that essentially we've got, and again highlighted in white is the areas of late gadolinium enhancement. We've got complementary information between FDG PET and late gadolinium enhancement. And so just to pause on this for a second so we understand what the FDG is actually doing. So normally the myocardium has some basal glucose metabolism, and that shifts based on whether or not we've been eating recently or we've been in a fasting state. But often, especially if we're eating regularly, we'll have a basal glucose metabolism that's reasonable to have significant uptake of a glucose-based tracer, which is fluorodeoxyglucose. And this indeed has been used for looking at viability imaging of the myocardium with PET. If we put ourselves in a state of hibernation, essentially, we just don't eat for about 12 to 18 hours. So if we have a period of fasting, the myocardium will shift its metabolism from glucose into free fatty acids. And so it won't take up very much glucose at all. And so then what's left has to be a very highly metabolic tissue or cellular substrate to be able to take up gadolinium in that area, and that's what macrophages are. So macrophages are revved up and they love to gobble up some glucose. And so after a period of about 12 hours of fasting, and then usually giving a lipid-heavy meal to the patient as well to further shift them into free fatty acid metabolism, and then we'll often also give a dose of heparin. Heparin also promoting suppression of glucose uptake into the myocardium. This leads to essentially a capacity to show signal only related to inflammatory cellular infiltrate, specifically macrophages. And so what you're seeing here is really a map of macrophage activation. And so this offers a really unique capacity to look at the metabolism of inflammatory myocardial disease. And about a year after we published that, we saw a very similar report coming out, and this was from Schlosser's group, in acute viral myocarditis, again showing very similar pattern of disease with SubEpicardial, this time along the anterior wall, with really transmural FDG uptake. And so it supports that PET MRI may actually be, in combination, the most robust imaging technology that we have to date for imaging acute myocardial inflammation. Now, we do have some other things that we could potentially look at, and this is more into the future, but high field strength imaging affords unique capacity to image things that we don't normally. So we usually image hydrogen, but at higher field strengths, we have the ability to study other elements. So for example, we don't have a lot of fluorine-19 in our body. In fact, so little that even if we tune our scanners to that frequency, we won't see very much. If we actually put fluorine-19 into perfluorocarbons that we can inject into the system, they'll actually get taken up by macrophages. And in high enough concentration, when we're at high field strength, it will get significant signal. This allows us to be able to get fluorine-only images with absolutely no background signal, which we can superimpose on hydrogen imaging. So these early work, and this is only just published in 2013, this is in rodents, allows us to actually study a potential very sensitive and specific marker of inflammatory infiltrate into the myocardium. And this signal correlated highly with macrophages on histology. Another approach, again exploiting higher field strengths, is this imaging, which is iron oxide nanoparticles injected again intravenously and taken up by macrophages. And it leads to significant disturbance of the local magnetic field, especially at higher field strengths. So this is really iron oxide gobbled up by macrophages, as shown on the histology here, and allowing us to see a reduction in signal that maps out very closely to histologically what we find to be myocarditis. And this was done in a rodent model of autoimmune myocarditis. Now, there are actually clinically available agents that we can use to do this, which have been used for iron replacement therapy in the setting of renal failure. And so these are FDA approved for that indication in patients with renal failure. And so the potential exists to now take this work into human study in the setting of acute myocarditis. So, but what should we expect today from cardiac MRI? And so we've talked about some things on the horizon, but today, in 2015, what should we expect when we order a cardiac MRI? And we definitely are going to expect cine imaging. There's no doubt about that. And so the capacity to get accurate prescription and analysis of both left ventricular volumes, function, mass, and wall thickness is certainly there, and obviously to look for any pericardial effusion. That's going to be at the core of any imaging study. T2-weighted imaging, I think, is going to maintain itself as part of the core protocol for some time. I think that a lot of clinicians, if they do see abnormalities on late gadolinium enhancement, are still going to want to know, is this a recent injury pattern or not? In isolation, does it identify myocarditis if you have no other abnormality on imaging? Probably not. There is maybe a couple of cases where it has been questioned whether or not you can have myocarditis with abnormal T2-weighted imaging and absolutely no late gadolinium enhancement. I think it occurs, but rarely. But what we are seeing is a migration towards more quantitative imaging that has higher sensitivity and hopefully specificity as well, and that's with respect to doing native T1 and T2 mapping. I do think that late gadolinium enhancement is still considered to be the most reliable tool for detection of acute myocarditis, and certainly the only one with good prognostic information at this time. But I do think that over the next 5 years, we're going to see emerging the expanded use of native T1 and potentially T2 mapping, but I think it will first emerge with T1 for the detection of increased tissue water. And that as a potentially valuable tool for not just identifying the presence of acute myocarditis, but being able to potentially provide a continuous variable by which it can be monitored for serial surveillance and for disease activity. I think that this remains to be seen whether or not there is any real prognostic information that's going to come out of this that is incremental to late gadolinium enhancement, but that's going to be an area of active investigation. So when should you order a cardiac MRI practically? Well, I think that we can safely say that it's reasonable to order a cardiac MRI to establish the cause of new onset heart failure. I think that there's enough body of literature suggesting that it's a valuable tool, that it's had recent robust appropriate use criteria assignments within guidelines, and I think that it is not an unreasonable test to order in somebody with new onset heart failure. There are ongoing investigations, certainly in Canada, looking at whether or not that actually changes management or whether it's prognostic. But I think that certainly in the setting of suspected myocarditis, it's a very reasonable test to order. And I think that also in patients with suspected ACS that go on to have normal coronary imaging, confirming the diagnosis of acute myocarditis with MRI not only has the value of providing a confirmation, but also providing some prognostic information. I do think that being able to identify other potential causes, such as sarcoid, and sometimes we see Scherk-Strauss, that is amenable to high-dose steroid therapy, I think that this is something worth considering in patients that present with with acute myocarditis, because we do see a subset of those patients that have very characteristic findings. Early risk stratification, I do think that we've got some early demonstration that we can predict patients that are more likely to have functional recovery. I think this is still an evolving field, though. I think we have lots to learn, but I do think that we have potential value in trying to discriminate those that within the first 6 months or so are going to have either recovery of function or go on to have complications. Certainly, it's of value for potential surveillance, and I think that with the addition of T1 mapping, being able to identify resolution of inflammation, it may emerge and may be able to identify people that shift into a chronic inflammatory state where they don't have complete suppression, and that might bring across some new potential for intervention, such as treating those people with immune modulating therapy. And then finally, obviously, there's going to be an ongoing need to identify patients that are at risk of future arrhythmic events for ICD, and also appropriate management or planning of CRT. So I'm going to stop there, and if there's any questions at all, we can receive them either verbally, or you can actually type them in, or if there's any questions in the room, we can take those.